So hello, everybody, and thank you very much for joining us. It's a pleasure today to have Dr. Modi from New York. He's a pediatric otolaryngologist, and he's going to speak about advanced endoscopic airway surgery. Dr. Modi, welcome, and thank you for joining us.
Thanks for having me. I appreciate the invitation. Looking forward to the talk.
Great. And we're going to have also Dr. Talal Khatib joining us. He's a sort of our local expert guide. He's a very prominent pediatric otolaryngologist in Saudi Arabia. He was just messaging me on the WhatsApp, so I think he's going to join us in a few minutes. So Dr. Modi, please go ahead. You have the podium.
Sure. Great. Thank you. I wanted to thank Moaz Harabici for the invitation, and I look forward to the talk. So I'm going to go over, I'll share my screen first. Let's see. Can you see what I'm seeing?
Absolutely, yes.
Okay, fantastic, great. So I'm going to talk about endoscopic pediatric airway surgery, which is my area of expertise. It's the reason why I came to New York and joined Cornell Medical College and New York Presbyterian Hospital. And I'm going to go over some of the basics, and then I'm going to talk about some of the advanced techniques that are now available, which necessarily weren't available even 10, 15 years ago, but with better instrumentation, lasers that can get to all different angles. Pediatric airway surgery really has changed a lot in the past 10 years. I have no disclosures. I always like to start off from the basics. So we always go over airway history first. Lauren Hollinger is somebody who trained me out of Chicago, who is now retired, but he always taught me to use the SpecStar mnemonic, which is sort of highlighted here in yellow on the left. So anytime a child has an airway issue, you want to assess the severity. Is it mild, moderate, or severe? Are the symptoms progressing? Are they stable, or are they improving? And what's really important for me, because when you evaluate a child in your office, you're seeing them for maybe 15 minutes, maybe 30 minutes, and maybe that's the best 15 or 30 minutes they've had the entire day. And you really want to make sure, is there any eating difficulty? And the way we do that is I actually like to plot their weight curve to see, are they at the 5th percentile, the 10th percentile, at the 30th percentile for their weight? And if a child is really having respiratory distress, they breathe a lot faster, and just about every calorie they're taking in, they're burning off breathing. And so if you notice they were born at the 30th percentile or 40th percentile for weight, and now they're at the 5th percentile for weight, in my mind, that is a big red flag. If a child ever turns blue, ever has a cyanotic event or has an apparent life-threatening event because of airway distress, that is also a red flag and warrants further sort of investigation. Now, some kids are doing great while they're awake, but when they go to sleep, they have difficulty. And majority of my patients I'm going to be talking about today, they're going to be all sort of kids under the age of 2 years of age. So it's mainly for congenital airway lesions, and sort of how do we manage it? So sleeping difficulty, that can happen as young as, 2-3 months of age, and that's also a red flag. And finally, do they have any radiography, any films, any airway films, any chest x-rays, any CT scans? Because sometimes that can provide you with some clues. Different parts of the airway produce different sounds. The nose, the nasopharynx produce stutter, snorting, or grunting. The oropharynx, hypopharynx produce snoring. The larynx and trachea produce stridor, and then the lungs produce wheezing. So just by hearing what kind of sound the child is creating, because oftentimes they can't give you a history, and the history you're getting is by proxy from the parents. So just trying to really pay attention to sort of what that sound sounds like can kind of help you delineate where the airway lesion is. Today, I'm going to be, there are multiple airway locations. There's the nasal cavity, the oral cavity, the larynx, the trachea, nasopharynx, oropharynx, hypopharynx. Today, I'm going to be focusing mainly on the larynx, the oropharynx. So we'll start out with oropharyngeal lesions. So oropharyngeal lesions include vascular malformations, follicular cysts, which we see here in the video on the right, dermoid cysts, foregut duplication cysts, intralingual thyroglossal duct cysts, and lingual thyroids. And these can all be managed endoscopically. So at the bottom, you'll see here, this is an example of a ball valving dermoid cyst. And you can see the scan, it's displacing the epiglottis here posteriorly. I'd say the most challenging part about this case is intubation. So you want to make sure you have a good anesthesiologist who can help you. And oftentimes ENT does the intubations in these cases. You can see here this dermoid cyst has just a very small stalk to it. And so I like to use the Omnia Guide laser, which is a fiber optic laser, or you can use luminous fiber optic laser to sort of get around the cyst. You grab the cyst with a cup forceps, and then when you're getting closer to the endotracheal tube, you don't want to use the laser anymore because there is that risk of airway fire. So oftentimes we'll even cover the endotracheal tube with a wet pledget while we're using the laser, and then once we're not using laser, we'll remove it. You can see here, use cold steel at the end. And interestingly enough, this child is missing a left-sided aryepiglottic fold. Once again, these fiber optic lasers are great. You don't rely on the microscope and line of sight. We'll show you an example of an intralingual thyroglossal duct cyst. Now, anytime you see a child where you're doing a flexible scope and the epiglottis is retroflexing posteriorly, like you can see here, the epiglottis is sort of prolapsing into the larynx. You always want to see, well, why is that happening? Is there something wrong with the epiglottis, or is there actually something pushing the epiglottis? And in this case, you can see there's a base of tongue mass here pushing the epiglottis here posteriorly. A CT scan shows a lesion here at the foramen cecum. And not many thyroglossal duct cysts are intralingual. Only, I'd say less than 1% of all thyroglossal duct cysts are intralingual. We'll sort of go over the video. You always want to make sure you have laser safety precautions. Even in these cases, I used to like to use a Hopkins rod telescope. You can put that inside the laryngoscope, or you can put that outside the laryngoscope with a 30-degree view. And here it is. It's the intralingual thyroglossal duct cyst sitting at the foramen cecum. We'll cover the endotracheal tube with a wet pledget. And what I like to do is I like to cauterize the entire surface of that intralingual thyroglossal duct cyst. And what this allows for hemostasis. So when you grab the cyst, it doesn't bleed. So you'll see, we'll speed it up pretty quick here. We'll cauterize that entire surface. That shrinks it down, and then we actually enter the cyst. And I like to enter it right at the foramen cecum, and you'll see we'll do that here in a second. Right there. And you notice that's the typical thyroglossal duct cyst mucus that comes out. We'll decompress the cyst with a suction. Because remember, this is sitting in the midline, and if you go a little bit laterally, you can get the lingual arteries. So here's what we'll do. We'll try to remove the entire, as much as the cyst as we can. Right now, we're removing about 75% of that cyst wall. And I'm using the micromanipulator here on the microscope. Very small spot size. You want to use it more of a cutting instrument, and you really want to stay midline. The goal here is to really exteriorize that intralingual thyroglossal duct cyst. So removing as much as you can is great, but there's going to be microscopic disease here that you're not going to get. So there you go. About 75% of it's removed, but there's going to be some residual mucosa there. So now we'll grab the cup forceps and try to grab any sort of residual cyst wall that we see, any mucosa. This comes out in a piecemeal-like fashion. You don't want to try to take it out en bloc, because then you're going to risk injuring the lingual arteries, which is going to be a big problem in a child. So there you go, just seeing remnants mucosa here. And now I'm using the luminous fiber optic CO2 laser, which kind of allows for, getting to crevices and nooks and crannies that you can't necessarily get to. Once all visible mucosa has been removed, you'll see I'll grab another piece here. You can see there's a little cyst wall there. You can actually palpate the hyoid bone when you're really going this steep. And, majority of intralingual thyroglossal duct cysts presents in kids younger than 3 to 4 months of age. So any child with stridor always deserves a scope, because you could be missing an intralingual thyroglossal duct cyst. Although rare, it does happen. And now we'll put the Lindholm laryngeal spreader, and I just like to sort of laser ablate the base and the entire cavity, make sure any microscopic remnants of mucosa have been vaporized. And you'll see, we'll let it down, and this is what the cavity looks like. You notice we stayed very midline. So that's the final view. And then I'll just fast forward a little bit here. 1 week post-operatively in the office, You'll notice a fibrinous exudate that sits in the base of tongue. The epiglottis is no longer being pushed posteriorly. And then when you look at them 2 months postoperatively, that entire area is healed usually pretty well. Notice the base of tongue there, very nicely healed. A little scar tissue there. But you want to keep an eye on these kids for up to a year because they can recur. And if they recur, it usually just takes one more endoscopic procedure, just like we did. We published our work in Laryngoscope recently, and that entire video is available on Laryngoscope as well. It talks about all the instruments, all the setup, laser settings, everything. Now we'll move a little lower down to the larynx. So this is a great diagram I got from the Philippe Monnier book. And these are all the lesions, and different parts of the airway have different lesions. Majority of these cases are going to be laryngomalacia, but that's still only about 60%. So meaning 40% are some of these other lesions. And you want to make sure, this is why we scope all kids who have stridor, because you could be missing one of these other lesions. And some of them, like a subglottic hemangioma or a saccular cyst, can be catastrophic if left untreated. Different parts of the airway produce different noises. The supraglottis produces inspiratory stridor. The glottis produces biphasic stridor. The subglottis also produces biphasic stridor. And the trachea produces more expiratory stridor than inspiratory stridor. The lower down you go into the trachea, meaning once the trachea becomes intrathoracic, the expiratory stridor component is larger. So once again, the sound can give you a clue. So we'll start out with laryngomalacia. It's the most common cause of stridor, most common laryngeal anomaly. You guys are well aware of this. Symptoms are inspiratory stridor, difficulty feeding, and a lot of these kids will have reflux because they have discoordinated swallowing because of their breathing issues, and they swallow out of air, and then that can lead to reflux. Time frame usually begins in the first few weeks of life, peaks at about 3 to 6 months, and then tends to improve. That being said, that doesn't happen in all cases. We've also found that usually mothers, when they deliver their child in the hospital, usually the first 2 days, there's no stridor. Stridor usually starts around day 5 to 7. Usually while they're in the hospital, you don't notice any noisy breathing, and when you ask the parents, you don't. That being said, if a child does have stridor in the first day or 2 of life, they are most likely to go on to need a supraglottoplasty because their conditions tend to be a lot more severe. So there are 3 different types. There's type 1, where the arytenoids just sort of prolapse in. You can see here. There's a type 2, where the epiglottis is very curled. And the reason why it's curled is because those area epiglottic folds are very tight. So the epiglottis becomes very curled. And a type 3 is extremely rare. Happens less than 5% of cases of laryngomalacia. And that's where the epiglottis entirely prolapses into the airway, obstructing the airway. And we tend to see that more in kids who have neurological issues or syndromes, also associated with low tone or hypotonia. Any child who's got a type 3 laryngomalacia warrants a neurologic and genetic workup. So the history is inspiratory stridor, increase with agitation and feeds, frequent spitting up, and once again, remember that poor weight gain. So if a child has got laryngomalacia and has got poor weight gain, in my mind, that's a red flag. If they start at the 30th percentile for growth and now they've dipped down to less than 5%, that lets you know that this is a big problem. These kids will have a rapid respiratory rate, nasal flaring, air hunger during feeds where they keep choking or breaking off their latch. They can have neck or chest retractions in severe cases. They can also have pectus excavatum where the chest starts to cave in. These kids, we want to do a flexible scope exam. We used to get airway films. I don't anymore, but we also used to put children on proton pump inhibitors, but now we found that can lead to bone issues later in life, so we put them now on an H2 blocker and reflux precautions. Now, that being said, 10% of these kids do go on to need surgery. The indications for surgery are failure to thrive, dysphagia, aspiration, hypoxia, recurrent cyanosis, obstructive sleep apnea, pulmonary hypertension, cor pulmonale, and pectus. Notice this child, very cachectic, very skinny, the chest is caving in, nasal flaring, rapid respiratory rate, and this child started at the 50th percentile and went down to the 5th percentile, despite medical management. So this is how we do the surgery. I like to use a cold steel technique. And what I'll do is I'll grab a Boucher or a cup forceps and I'll take a carved scissor. And I like to use cold steel technique. And I really want to cut right along the epiglottis there to divide that area epiglottic fold. And as you start dividing, there's a little blood vessel that comes, and that's when you know when to stop. So you'll notice a little bleeder. or a little blood vessel kind of comes into view there. I divided the other side, and now we'll grab the cuneiform cartilage, and I like to remove that as well. The key to this surgery is to not violate the interretinoid mucosa. When you violate the interretinoid mucosa, that's when you can have supraglottic stenosis. But you can do both sides as long as you leave the interretinoid mucosa intact. And then I'll just take an Afrin-soaked pledget or an oxymetazoline-soaked pledget, leave that on there for a few minutes and remove it. And I'd say really the key to this picture, you notice the epiglottis no longer is curled. Whoops. Let's fast forward here. Notice the epiglottis is no longer curled because once you release the AE folds, the epiglottis becomes uncurled, but the interretinoid mucosa is left intact. And I think that's really, really important for preventing posterior glottic stenosis or supraglottic stenosis. Now, what happens if they recur? So this is what they look like on the table after surgery. And when you look at them in your office, this is what they look like 1 week postoperatively. You can notice now, you can see the vocal folds opening and closing. You can see there's a little scar tissue on the AE folds where we divided it. The epiglottis is no longer curled. And there's little scar tissue sitting over the cuneiforms where they used to be. Now, majority of the time, I would say the success rate of supraglottoplasty in my hands is about 95 to 98%, meaning they don't need revision surgeries and they're done. But then there are kids where the parents stop the reflux medications or they stop practicing reflux precautions and their symptoms come back. So this is a child where you can see here, the child's symptoms came back, the area epiglottic folds, whoops, scarred back again. And in these kids, what we'll do is we'll make sure the parents do continue those reflux precautions, put them on the H2 blocker again. But what I like to do, I like to redivide the AE folds, and over here I'm trimming one side of the epiglottis. And you'll see here the final view here in a second. Another thing that can be done, in addition to trimming one side of the epiglottis, is you can actually do an epiglottopexy, where you take one stitch and you stack it up to the base of tongue. You laser ablate the lingual surface of the epiglottis and the base of tongue, and then you throw in one stitch. The epiglottis doesn't keep getting displaced posteriorly, because if it does, then those AE folds can sort of scar down again. And you know, in my practice, I've had to done over the years, over 12 years, I've done maybe 5 sort of revision supraglottoplasties. And oftentimes it is due to parental noncompliance, but it can also be due to low tone, where you need to do something extra. Here's a child with sleep-dependent laryngomalacia. We oftentimes will see this kid in low tone kids, where the epiglottis just sort of prolapses their posterior. The glossoepiglottic ligament is just very lax. And in these kids, we'll do an epiglottopexy. And the way you do that is you demucosalize the vallecula with the laser. You make sure you want to leave a little rim of mucosa, and then you try to get in as many sutures as you can. We'll do a nasotracheal intubation. These are the instruments we use. If they have lingual tonsils, which are in the older kids, I'll use a Koblator wand to sort of remove the lingual tonsils. And this is what you want to do, essentially. You want to laser ablate all the mucosa. And you notice here, I've left the rim of mucosa here circumferentially around the epiglottis. And the reason why you do that is because the epiglottis really acts as a funnel, and it funnels food down into the esophagus. And if you do a complete epiglottopexy without leaving this rim of mucosa, the epiglottis becomes too adherent and the child can aspirate. But if you leave this rim about 2 millimeters here circumferentially, you do not have that problem. And so here's an example of the epiglottopexy. I showed you the sleep endoscopy, Lindholm laryngoscope, put a wet pledget here on top of the endotracheal tube, and we'll demucosalize with the fiber optic CO2 laser. In this case, this is the OmniGuide laser, but you can use any laser you want. You've got to practice laser safety precautions, and once you've demucosalized it, you wipe it off with a wet pledget, and then you place a suture. And the goal here of the suture is to place it through the base of tongue, through the perichondrium of the epiglottis. You don't want to go through the entire epiglottis, because if you do, you can strangulate the epiglottis, you can necrose the epiglottis, which has happened in case reports. So in super young kids, I can get maybe 2 stitches in, 3 stitches in. In the older kids, I can get up to 5 sutures in. I found 2 populations that need this: kids under the age of 1, and then Down syndrome kids close to the age of 4 or 5. And you notice the epiglottis now is more superior. I'll usually use a Karl Storz knot pusher to push down these knots. And this is your final product. So we see this in young kids, and then we see this in around kids between the ages of 5 and 10 who have Down syndrome. And when you scope them in the office, you notice that epiglottis there is adherent to the base of tongue. Notice there is a rim of mucosa that is around on the lingual surface of the epiglottis, which allows the epiglottis to still function and prevent aspiration. But it's adherent to the base of tongue there. Now, what if they've got lingual tonsils? So remember that those Downs kids that are older, here's a child who's got massive lingual tonsils, adenotonsillectomy was done, still continues to have sleep apnea. And so I will usually coblate the lingual tonsils on a setting of 8. We'll do the right side first. And the key really here is to keep repositioning that laryngoscope, otherwise you'll miss some lingual tonsil. So we'll reposition to the midline, remove some more lingual tonsils, and we'll reposition to the left, remove a little more lingual tonsils. And this is sort of what your final product looks like. And if you've removed all the lingual tonsil, you can actually get sutures into the base of tongue, and they will hold. You want to use a taper needle here because otherwise it'll just cut through. Notice that rim of mucosa around the epiglottis there, and we're suturing it through the perichondrium. In this kid, I think I was able to get 3 sutures in. That's what it looks like. This is after the knots have been tied. And you notice the epiglottis is there sitting more anteriorly. And this is what it looks like in your office. You notice the fibrinous exudate where the lingual tonsils are removed. And this is just 1 week post-op. And these kids do not aspirate. Post-op care is all here. We did write this up in the How I Do It section of Laryngoscope as well. You can look it up. The video is there as well. Now a little lower down to saccular cyst. So saccular cyst is a pinching off of the ventricle. The symptoms are similar to laryngomalacia, and you can aspirate, you can marsupialize, you can do open excisions. I prefer to manage these endoscopically. And if you're in a crunch and you're in a bind, and the child is, only 2-3 months old, has massive respiratory distress. So here's the example of a saccular cyst sitting here on the left side. You can't even see the vocal cords. And this child is going to have major respiratory symptoms, but can present sometimes with just stridor. You can see here, there's a scan. It is quite large. And you want to get the scan to see, is this internal, is it external, is it both? So this child was very, very young. So I started out with just a marsupialization. And what you're doing is I stuck a needle in it. You notice all this mucopurulence come out. And then I grabbed the top of that cyst and I removed the entire sort of superior wall of it. Remember, you don't want to cut that glossoepiglottic ligament, because if you cut that, then the child will aspirate. So you want to leave the glossoepiglottic ligament intact. After that top has been removed, we'll push from the outside of the neck. You notice more mucopurulence comes out. And then we irrigate the cavity. And this is nice because it'll get you out of a short bind. Meaning if you're in a tough jam, and this is what it looks like post-operatively. But before that, let me show you this cyst cavity. It is quite large. You see, it goes quite deep. So, this will work in maybe about 20% of cases if the cyst cavity is not that big. And some people actually take some silver nitrate and sort of try to get all the mucosa and cauterize it. But I think marsupialization has a high recurrence rate. And I think if you've got the space, you really should do an extended ventriculotomy. So here's a recurrence 7 weeks later when the child had an upper respiratory tract infection. And in this case, we did an extended ventriculotomy. And what you're doing is you're removing the entire false vocal fold. And that allows for the natural drainage of that ventricle. So here you can see here the endotracheal tube is in place. Once again, I like to use cold still technique as much as possible. Hemostasis can almost always be obtained with just an oxymetazoline soaked pledget or an epinephrine soaked pledget. And you can see here, we're removing that entire medial wall. And then I took a cup forceps and we grabbed some more mucosa. After that, an epinephrine soaked pledget is placed into that area. And here's our cavity. Notice the true vocal folds have not been touched. And there's your entire cavity here, but you notice that there's a massive sort of hole we've placed there, and that allows for almost externalization of that cyst. Because you're not going to get every microscopic disease, but you want to externalize that, the saccular cyst. And so this is what it looks like in your office. Notice there's a fibrinous exudate sitting in that false cord, which is no longer there. But this kid did not aspirate, had no swallowing function issues, had no voice issues. And this is what they look like at 1 year follow-up in your office. And you do want to follow all these kids for at least 1 year. And notice there is a cavity here sitting in the false cord, or where the false cord used to be. But that patient does not have any symptoms either. And we've actually published that video on csurgeries.com. If you guys want to look at it, it goes over all the instruments, the indications. So we'll move over to vocal fold paralysis. It's the second most common laryngeal anomaly, typically hoarse cry. These are all the etiologies. The two most common are birth trauma and cardiovascular trauma. And this is very similar to adults, how you manage it. These kids will have a hoarse or breathy cry. Always want to scope these kids. If you don't have an obvious reason why the cord is out, like if they had a PDA ligation, you know that is an etiology for vocal fold paralysis. But if they haven't had any cardiac surgery and you don't have a reason why this happened, you should get an MRI from the skull base to the mediastinum to look for any issues, whether brainstem issues or issues along the recurrent laryngeal nerve. And if these kids are having recurrent aspiration pneumonia, despite thickened feeds, or if they got persistent hoarseness at 1 year of age, I'll do an injection laryngoplasty. I don't like to do it in super young kids because it can obstruct the airway. So here we go. You don't want to inject the cord itself. You move the false cord over to the side, and I'll usually inject in 2 locations to kind of make this vocal fold more median. And you'll see I'll just fast forward this, and you'll see there's the injection. We'll do a second site injection as well. I like to inject voice gel, something that is absorbable. I don't like to put permanent fillers in young kids because we don't know what the long-term effects of that will be. But you notice here that vocal cord now is more midline, and this patient had a competent glottis afterwards. So bilateral vocal fold paralysis is 30% of all vocal fold paralysis bilateral. And typical biphasic striders, what they present with, this is what your scope exam looks like. Now, you notice there are 3 common etiologies, but look at these recoveries. 71% recover, 64% recover, 46% recover. I'd say about 50% of all bilateral vocal fold paralysis recovers. So oftentimes in these kids, about half of these kids will require a tracheostomy if it's congenital bilateral vocal fold paralysis. The other half will just make it by and they'll eat and feed okay and they'll do great. If a child cannot feed well or cannot breathe well, then I'll put a tracheostomy. I won't do a chordotomy. I don't want to do a destructive lesion in a very young child. I don't even do sutural lateralization because it's really challenging in this age group. You put a tracheostomy in and you wait, because about 50 to 70% of these kids are going to recover spontaneously. So you don't want to do anything destructive. And then once their vocal fold function recovers, then you can always decannulate. It's a tough sell to the parents, but that's the way we manage it. If by age 1, they still are unable to be decannulated because of respiratory compromise, then I'll do an endoscopic posterior cricoid split with rib graft. So this is the cricoid ring. We'll divide the cricoid endoscopically and put a rib graft in, and I'll show you what that looks like. So this is a child with bilateral vocal fold paralysis, and we've published this paper as well. Lindholm laryngoscope, Lindholm false cord retractor is also very useful. Laser safety precautions. So this is suspension with a Lindholm laryngoscope. Notice this child has no other lesions aside from their vocal fold paralysis. We'll put the Lindholm laryngeal spreader in the false cords, not the true cords, and we insert it in an inverted fashion. I'll use the micromanipulator here because I want the smallest spot size possible on the microscope, and with the fiber optic laser, the spot size ends up being very large. You take your straight suction, you move the interretinated muscles posteriorly so you can access the cricoid plate, and I'll divide the cricoid endoscopically, and it's very important to not divide the perichondrium here posteriorly. We'll measure the length of that defect with a straight suction, then we'll harvest a rib graft, and notice we'll carve the rib graft with perichondrium only on the luminal surface. These are the average dimensions for the rib graft. And then we'll insert it into the posterior glottis. So the nice thing about doing it this way is you're preserving the cricoid ring. So there's some spring to the ring because you've only divided it in one location. And the graft will just sort of snap in there. And if the graft doesn't fit on the first, second, third, fifth try, then you trim the graft and you try to put it in again. And what this allows you to do is it gives the kids with bilateral vocal fold paralysis, their baseline resting position of the cords stays distracted, stays about 5 millimeters open when you initially do the surgery. And then when you see them at 1 week post-op, that 5 millimeters of distraction that you've got in the posterior glottis then narrows down to about 3 millimeters. And when you look at these kids at about 3 months or 2 months post-op, or even 1 month post-op, that 5 millimeter distraction goes from 3 millimeters down to like 2 millimeters. And the nice thing about this is it's not a destructive procedure. You haven't burned any bridges. It preserves voice, preserves swallowing, and it keeps the resting position of the vocal fold just slightly distracted, which is all these kids need to be decannulated. We can also do an endoscopic posterior graft for posterior glottic stenosis. So here's a child with posterior glottic stenosis. We divided it endoscopically. We left the perichondrium majority of intact, inserted the graft. This is the day of surgery, before and after graft. This is 1 month post-op, before surgery, after surgery, and this is 3 months post-op. This is before surgery. This is 3 months after surgery. And notice their posterior glottic stenosis is now sitting quite well. We did publish our study on the White Journal, and you can look it up. It goes over our techniques. We had 29 patients who underwent an endoscopic graft. 23 out of 29 had tracheostomy present. 21 out of 23 were decannulated. 6 out of 29 did not have a tracheostomy and all avoided a trach. And the decannulation or avoiding trach rate is about 93%. So it's a very, very good surgery. Andy Inglis was the first to describe it out of Seattle. And so that's why I call it the Inglis procedure, but it's really called an endoscopic posterior cricoid split with rib graft. These are our average graft dimensions. Bunch of tips and pearls. You can read the paper that kind of goes over all these tips and pearls. And here's our reference. I've written it up there. I won't, sort of go over all the nuances of the surgery. We've published both of the videos on csurgeries.com that also goes over the technique and how you do that. If you guys want to look up the surgery for endoscopic graft for vocal fold paralysis as well as posterior glottic stenosis. Now we're going to move a little lower down to laryngeal clefts. It's a posterior midline defect between the larynx and the esophagus. It's associated with those 4 syndromes. A type 1 is just interarytenoid only. Type 2 goes into the cricoid. Type 3A goes through the entire cricoid. 3B goes into the cervical trachea. A type 4A goes into the thoracic trachea. And a 4B goes into the bronchus. This is a diagram I did take from the Philippe Monnier book as well. If you are into pediatric airway surgery, I strongly encourage you to purchase the Philippe Monnier book. It's called Pediatric Airway Surgery. It's fantastic. It has excellent illustrations, very well thought out, a lot of good references in there. So once again, with swallowing, remember the epiglottis funnels the food back into the esophagus, but if you've got a posterior defect here, these kids are going to aspirate. So these kids will have cyanosis during feeds, apparent life-threatening events, recurrent aspiration pneumonias, they'll cough with feeds, and when you scope these kids, all you see is an edematous larynx. You cannot diagnose a laryngeal cleft on a flexible bedside exam. First, if they are aspirating or there's coughing with feeds, you'll get a video swallow study. Feeds, a lot of people will do. I find it challenging in super young kids. And if they are aspirating, you get a laryngoscopy and bronchoscopy to see if there's a type 1 cleft. And here's the key when you're doing your laryngoscopy bronchoscopy. You want to take your curved angle probe, put it in the interarytenoid region, make sure this partition is above the level of the vocal cords. This child does not have a laryngeal cleft. This is a normal sort of, this is a normal interarytenoid depth. We'll give them some speech and swallow therapy and put them on thickened feeds. But if they do have, this is an example of a type 1 laryngeal cleft. Notice that interarytenoid region goes down to the level of the vocal cords. And these kids do not tend to aspirate thickened, they tend to aspirate just thin liquids. And you can see that's just a very, very deep groove there. This is an example of a type 2 laryngeal cleft. Remember, type 2 goes partially through the cricoid, so it goes past the level of the vocal cords. And here's a kid that goes past the level of the vocal cords, and these kids will aspirate everything, almost all consistencies. Recurrent aspiration pneumonias really have a lot of respiratory distress. This is a patient with a type 3 laryngeal cleft. And you can see it goes through the entire level of the cricoid into the cervical trachea. And you can see how deep that this really does go, quite far down. And this is the type 3 cleft with a laryngeal spreader intact. And you notice now here we are going, this is a type 3B actually. It goes into the thoracic trachea. Remember, the carina is only about 2 centimeters away from you here. And these kids will have respiratory distress, not just aspiration. So endoscopic repair, excellent voice calcium, fewer wound complications, no tracheostomy. The cons is it requires adequate access. The open repair has better access, but you may require trach. These kids will have poor voice outcomes because they oftentimes will need a laryngeal fissure. It may make tracheomalacia worse because these kids will have tracheomalacia and you can have some wound complications. So let's start with type 1 first. Oftentimes it's unclear if the child is a type 1 and you can try to test things by just injecting a little bit of a filler in there, like voice gel. You'll inject it, something or bioabsorbable material into the posterior glottis. And the idea here is just to plump up this interarytenoid region so it is above the level of the vocal cords. And you'll notice here there's a ballooning and you're raising that interarytenoid bar a little bit more. You see there it is ballooning up, plumping up. And you'd get a video swallow study anywhere from post-op day 3 to 1 week out to see if their aspiration resolve. Now, a lot of these kids, you'll inject them and their symptoms never come back. And some kids, you inject them, the symptoms go away and then they come back. Or some kids, you inject them, it doesn't make a difference. And then you know it's not the cleft that's causing it. And you notice here, that level is above the level. Whoops. It is now, after injection, that interarytenoid region is above the level of the vocal cords there. Now, if you inject this material and their symptoms return, then you can go on to do a formal repair. And here's how you do a formal repair. It's actually a pretty straightforward procedure. So remember, this is a type 1 cleft. We'll insert the Lindholm false vocal fold retractor. And then I'll take a CO2 laser and I'll demucosalize a diamond shape in the interarytenoid region. I'll fast forward here a little bit. I'm using the fiber optic laser. This entire surgery takes about 15 minutes. It is pretty quick. Once you've demucosalized the region, you'll wipe it off with a wet pledget. So I'll use a double-armed 45 centimeter needle on a taper needle. And the nice thing about doing a double-armed needle is you can put one needle through one side, and you can put the other needle through the other side. And this way you're not posteriorly. You need a 45 centimeter suture so you have enough length to suture outside and then push it in. But you'll see here, I'll just go ahead and fast forward a little bit. We pull the needle through. And you can see the suture kind of wraps around and the knot's going to sit here posteriorly. So it's not really tickling the airway and causing irritation. We'll take our knot pusher, put the 2 knots in. Actually, I usually put in 3 or 4 knots. Take my curved scissors, which are never super sharp, but you do your best, not tear out the stitch. And then we'll release the false vocal fold spreader. And this is all without intubation, spontaneous ventilation. And you notice that interarytenoid region is higher than the level of the vocal cords now. Now, once you do a procedure like this, I like to scope them 1 week in the office. And if you've got a dyed suture, you can see the suture. And you can see there it is sitting in the posterior glottis. The knot is facing there posteriorly. And so you know your repair is held up. 1 month postoperatively, some scar tissue develops there. And these kids tend to do very well with the procedure. They spend 1 night in the hospital and the next day they go home. Type 2 laryngeal cleft, very similar. You laser the entire area and then you do a single mass layer closure. This is a type 2 being repaired. So instead of 1 stitch of a type 1 and a type 2, you may need 2 or 3 sutures, but very easy to do endoscopic. Type 3s are quite challenging. So this is a type 3. It was the initial baby I showed you. That was at 7 days of life, but we could not get sutures in because the baby was so small. what ends up happening with these clefts is the cleft edges start growing to the airway, and that child then starts to obstruct. So in that kid, we put a G-tube, fed them, got them to grow bigger, and then we repaired it at about 3 months of age when they started having respiratory distress from the cleft edges growing into the airway. So the key now is to remove the redundant mucosa first. You cut the laryngeal surface of the redundant tissue, then you cut the esophageal surface, and the key is to measure twice and cut once. So we're cutting the laryngeal surface or the luminal tracheal surface, then we cut the esophageal surface. And the key really is to get all the mucosa off that entire edge, all the way down to the apex at the bottom. And the most challenging part about this procedure is getting that distal suture in. We use an RB1 needle. We have to bend it on a Vicryl. And you can see this is a bent needle. The problem is if you don't get that distal suture in and it dehisces down there, it's very difficult to repair that area. So once the suture is placed, we'll use our knot pusher. Very important, you don't trap the esophageal mucosa when you're putting those knots down. This is a fast-forwarded video. I do not suture that fast. This is the third stitch being placed. This child required a total of, I believe, 8 sutures to close this laryngeal cleft. Notice that needle is still bent. And that's suture number 3 being placed, the knot pusher. Once again, don't trap that esophageal mucosa. I do about 3 to 4 knots. We cut the suture. Then this is the final and last 8 suture. And a taper needle is always preferred. And to reduce the tension on your anastomosis or on your suture line, I'll do a quick division of the area epiglottic folds, not too aggressive, but that decreases your tension on the posterior glottis there. So here you can see we're dividing the area epiglottic folds. Remember, really close to the epiglottis. And this is what your final view looks like, non-fast forwarded, real time, after placing 8 sutures, all without intubation, spontaneous ventilation. Very important to have a good anesthesiologist, but you can see the child does have baseline tracheomalacia. This is your 1-week post-op laryngoscopy. You can see the sutures are intact. You don't want to put your spreader in too much, but there you go, things have healed. But remember, the kid's got tracheomalacia. So if you approach this anteriorly, you have to divide the trachea anteriorly, and that can cause progression of that tracheomalacia. So the endoscopic from a voice outcome is really preferred. This is the day where the child had the G-tube removed, 9 months post-op. And you can see there is still some redundant mucosa there, but this intraretinoid level is intact. The whole area is intact. And one thing I want to talk about, this is not endoscopic airway surgery, but if you scope a lot of kids and a lot of newborns, you will see a vascular lesion in the posterior glottis. This is called a posterior cricoid cushion, and you'll notice it expand over here. Now that I've pointed out, you're going to see it more and more. This is not a surgical disease. You do not want to operate on these because they spontaneously go away by the time the child turns around 1 year of age. And physiologically, it's thought that it's a protective barrier so that when a child is crying vigorously, they can't vomit and aspirate because that dilation prevents emesis. And they come in all different shapes and sizes. This is a very large posterior cricoid cushion. This is not a vascular malformation. These kids do not need surgery. So if you do see these in your office, majority of the time, it's just a benign lesion that will go away. So we'll move down to laryngeal webs. It's incomplete recanalization of laryngeal tracheal tube, presents with dysphonia, airway obstruction, physical exam, you'll see a laryngeal web. And oftentimes we'll get airway films. You also want to do an anoscopy to see, is this a thin web or does this really extend subglottically? Because 30% of these kids will have subglottic stenosis. It is associated with these 2 syndromes, so you want to get a genetics workup anytime you see a laryngeal web. And there are 4 types: type 1, less than 35%, type 2, 35 to 50%, type 3, 50 to 75, and a type 4 is oftentimes laryngeal atresia, incompatible with life. These kids will usually require an exit procedure to save their airway. Type 1s and type 2s oftentimes can be managed endoscopically, but once there is subglottic extension, you need to do an anterior graft. So this is an example of a type 2. Didn't really have much subglottic extension. We divided endoscopically with a sickle knife. I'll fast forward this really quick. I like to use cold steel again because I feel like you're going to get less scar tissue development with that. So you divide it here endoscopically with a sickle knife, and then we like to place an endoscopic keel here, and I'll usually put that in from anywhere from 7 to 14 days. And this is a child who had a type 2 that did not have subglottic stenosis, so you could just manage this endoscopically. If they do have subglottic stenosis, you'll have to put an anterior graft in addition to an endoscopic keel. Go on to the next. I'm going to touch on subglottic hemangioma just a little bit, just because I think it's important to recognize it's no longer a surgical disease, but they'll have air hunger during feeds. Each episode of croup gets worse and worse and worse. And that's when you know that this is not just your typical croup. It stops responding to steroids, and each episode of croup gets worse. That's when you know the child warrants a direct laryngoscopy and bronchoscopy. And if you do notice a subglottic hemangioma like there is here, you want to get imaging to make sure that this is not extending deeper in the neck and that it's just isolated to the subglottis. We used to do all these sorts of treatment, including open surgical resection. Now all we do is propranolol. And this is a child with a 90% obstructing subglottic hemangioma. You can see quite large, pretty impressive, and then the remainder of the airway is normal. This is after just 4 days of propranolol. And you can see that it shrinks by at least 50%. And this is after 3 weeks of propranolol. And you can see there's some hemangioma there, but it's like less than 10%. It's like more hemangioma staining more than anything else. You can see there. And now you want to keep these kids on these beta blockers for at least 1 year of life because that's the proliferative phase of the hemangioma. So really, propranolol has stole all the fun out of hemangioma airway surgery, but I think it's better for the patient. So, Facey syndrome is diffuse hemangioma staining everywhere, and if you see hemangioma staining everywhere, you want to make sure you're getting an MRI or a CTA because they can have arterial anomalies with just a single carotid artery. They can have all sorts of other anomalies, and the last thing you want to do is give one of these children anesthesia and they have a stroke because they have some abnormal cerebral or cervical vasculature. So whenever you see diffuse hemangioma staining, you want to get a CTA or an MRI. I'm going to touch on subglottic cysts really quickly. So the subglottis has submucosal glands, and almost all these kids have an intubational history. They're almost always NICU babies, and they have progressive biphasic stridor. So if the exam looks normal in the office, but they have progressive biphasic stridor and they're a NICU baby, you're going to want to do a direct laryngoscopy and bronchoscopy to find out exactly what the etiology of their biphasic stridor is. And this kid, you can see, he's got about a 50% obstructing subglottic cyst. These kids can die if they get too big. It can completely obstruct the airway. And actually, the procedure is quite simple. You're essentially just marsupializing the subglottic cyst. I like to use either cold steel or a CO2 laser. In these cases, the laser I like because it is hemostatic and you can get pretty deep. But you don't want to be lasering adjacent cysts, and the cysts can recur. And oftentimes these kids have multiple cysts. Just about every one of these kids were a NICU baby. And lastly, I'm going to touch up on airway balloon dilation. We've got about 12 minutes left. So traditionally, rigid dilation was performed for subglottic stenosis and thin stenoses. Problem with that is there's shearing forces, and you can cause collateral injury because you're taking a hard, solid rod and putting it in and out, and you can cause further injury. Balloon dilation has come in vogue over the last 10 years. It's easy to use. Primary treatment for thin and new stenosis. It can be an adjunct to open airway surgery. It's very precise. You can pick your exact measurement. You can pick exactly where you want to dilate. And if you don't have airway balloons, you can always use vascular balloons that have similar sort of properties. They have an oblong shape, consistent size, high stability, resistant to motion. We did a paper on, we wanted to find out what was safe for balloon dilation because, you know, if you use a balloon that's too big, these children can start to have problems. So this is a rabbit airway. that we did balloon dilation on to see, well, what happens if you use too big of a balloon? Do these rabbits die? Do they fracture their larynx? Do they have progression of disease? So we sized the airway, we sprayed the airway, and this is the rabbit. And we looked at sort of any injury caused by excessive balloons or big balloons and what sizes were safe. So what we did find was that the larger the balloon, you start to get mucosal injury, meaning you can make things worse. You can make subglottic stenosis worse by using too large of a balloon. And then what we found was that if you used way large of a balloon, these rabbits were actually dying on the operating room table. And they were undergoing cardiopulmonary arrest. So it is important to be sort of cautious with balloon size and balloon use. So we came up with a recommendation based on our study. So this is a Cotton-Meyer grading system, and this were the recommended balloon sizes based on age. Meaning you don't want to use a 9mm balloon in a 3-month-old baby. And there have been case reports of children dying on the operating room table from using too large of a balloon or fracturing the larynx. So in conclusion, our studies show that intraoperative mortality from cardiopulmonary arrest reaches 50% when the balloon diameter exceeds the airway diameter by 4.6 millimeters. Some of these rabbits had postoperative dysphagia, and that can occur from airway balloon dilation. It had no correlation with size or pressure. So anytime we do a balloon dilation on a child, we do admit them overnight. You can start to get significant mucosal injury if the balloon size is 2.6 millimeters larger than the airway diameter. Balloon size exceeding airway diameter by 2 millimeters can also fracture the cricoid. All the fractures occur at the anterior cricoid ring, and they do result in a larger diameter, but you can have the sort of consequences of dysphagia and all sorts of other problems and even death. So we found that inflation pressure doesn't really matter when you're using balloon dilation. What really matters is the size. So then the Cincinnati group then did a study with live rabbits with subglottic stenosis model, where they induced subglottic stenosis and then they did balloon dilation in those rabbits. Also another great paper. And we came up with this recommendation as a result. So if a child has subglottic stenosis, if it's acquired, meaning it is scar tissue, we do radial incisions with a knife, and then we dilate 2 to 3 millimeters larger than the age-appropriate airway. If they have congenital subglottic stenosis, so an elliptical cricoid, we'll do an endoscopic anterior cricoid split. So we divide the cricoid with a sickle knife with our hand on the outside, and we divide it endoscopically. And then we use a 2 to 3 millimeters larger than the age-appropriate airway, and we balloon dilate. If they've had a previous reconstruction, a laryngotracheal reconstruction or a cricotracheal reconstruction, you just want to airway balloon dilate to no larger than the initial reconstructed airway. Because if you do too big, you'll break up your surgery. So in conclusion, recent advances in technology and surgical techniques have allowed for endoscopic management of complicated pediatric airway problems. Newer technology should be used with caution. One should be aware of the possible complications of their application. And that's it. That's my talk. Thanks for having me, and I'd be more than happy to entertain any questions.
Thank you very much, Dr. Modi. It's a great talk. I have on the line sort of our local expert, Dr. Talal. Dr. Talal is a pediatric otolaryngologist, and he's a leader of our ENT community in the Middle East. But before I give the podium to Dr. Talal, how do you know that the rabbit is having a dysphagia?
That's a great question. So they just stop eating. They won't take any. So rabbits are very finicky animals. Anything goes wrong in their ecosystem or in their body, they stop eating. They don't even have a rapid respiratory rate or anything like that. They just stop eating.
All right. Talal, please, go ahead.
Yes, thank you, Dr. Maaz, and thank you, Dr. Modi. I really enjoyed your talk, although I do the same as you do, but very nice visualization and recordings of what you do. You conveyed the message very nicely to our audience. I congratulate you. And I have to say that really it's very hard to deal with rabbits. They die, and anything you do to them, they just make you feel bad.
Oh, yeah. You slam the door. If you walk out of the room and you slam the door, a rabbit will die.
That's right. So if you allow me, I'm looking at the chat and I'm seeing some of the questions in regarding to thyroglossalal duct cyst surgery that you showed us endoscopically. Yeah. There was a question about what about the hyoid bone? Do you do anything about it or about the periosteum of it?
Yeah, so that's a very good question. So, intralingual thyroglossal duct cysts, they tend to be centered right in at the foramen cecum and in the base of tongue. Now, there are some that are dumbbell shaped, meaning they have an intraoral component, but they also have a cervical component. So we'll always get the imaging to make sure there's no cervical component. If there's no cervical component, then I do not address the hyoid bone. If there is a cervical component, then I think the surgery of choice is to go transcervically to remove the hyoid bone. Now, there is one paper out there, actually, sorry, the paper hasn't even been published yet, I just reviewed it, where they did a robotic transoral resection of the intralingual thyroglossal cyst and removed a piece of the hyoid bone. I have not done that. I don't have any experience with that. That being said, I mean, I think you're going to get a tremendous amount of laryngeal edema and all sorts of edema if you try to resect the hyoid bone endoscopically, but it has been done. That patient did have a tracheotomy though. So use the hyoid bone doesn't need to be addressed.
All right, thank you.
And we're actually publishing a meta-analysis looking at all the endoscopic thyroglossal duct cysts that have been excised and what's the recurrence rate and how have they been managed. Recurrence rate when you excise it endoscopically is less than 5%. And in that 5%, if you manage it again endoscopically, the recurrence rate goes down to 0. So they don't recur in the neck or they don't recur around the hyoid.
All right, great. There's another question. They're interested to know about the stent you use, this elastic sheet for the glottic web.
Yeah.
What's the size? How do you trim it?
You want to use the thinnest sort of stylastic sheeting you can get. So really as thin of a piece as you can get, because once you start getting thick, it starts to dig into the vocal cords. So yeah, I just go to my scrub tech and say, give me the thinnest piece you can. Tell me what the otologists are using today, and that's the way I use it. And you just want to just make it so the V kind of forms up at the top, and you want to extend it. If you make it too small at the top, then the edges start cutting in to the vocal cords. You want to leave it long enough so that doesn't happen.
Terrific. There's a couple of questions that I will sum it up in one. They're basically asking about the adjuvant treatment to prevent scarring. Some asked about the steroids and some asked about mitomycin C.
Yeah.
Which conditions do you use adjuvant medications? And have you moved away from mitomycin and start using steroids, or the other way around?
So, I always like to go least invasive to most invasive. So initially, we'll just do radial incisions, balloon dilation, nothing else. If that fails, even the second time, I'll try maybe even another balloon dilation. If after the second time it fails, then we start going adjuvant. And first adjuvant I'll do is I'll inject Kenalog or I'll inject steroids. And I like to inject it before you do the dilation and before you do the radial incisions, because once you do the radial incisions and dilation, you can't really see where to inject. So I'll inject, divide, do 3 radial incisions, and then balloon dilate, and we'll revisit in a couple weeks and we'll see what it looks like. Now, after injection of steroids, if it's recurring, that's when we start really sort of moving into mitomycin, but I'll give mitomycin maybe 1 or 2 tries, probably just 1 try. Frankly, I've moved away from it a lot just because it's a pain in my hospital to even obtain it. Studies are sort of, some studies show it helps, some studies shows it doesn't help. But I think at that point, if your stenosis is recurring after multiple balloon dilations, steroid injection, mitomycin, I think the patient just needs an open airway procedure.
So do you have a formula for that? Like if I fail 3 times, 5 times, or it depends from patient to patient?
So first time balloon, second time balloon, third time injection steroid, 4th time mitomycin. After that, it's not going to work.
Yeah. Okay, so if you allow me, I have a couple of questions.
Sure.
One is, what are your thoughts about epiglottopexy in under 1 year of age? I've noticed you said you do it and I do it, but a lot of colleagues are skeptical about it because of aspirations and whatnot.
Yeah. So I have done it. So I've done it on my revision supraglottoplasties, or if it's just an isolated type 3, I'll do it. But as you know, I mean, it is difficult to it's difficult to get that suture in there. We'll do a pre-op swallow study, and we'll do a post-op swallow study. I don't see any of these swallow studies getting worse. Meaning, a lot of these kids were aspirating pre-op and they're aspirating post-op, and the aspiration isn't getting worse. I have seen kids that were aspirating pre-op that no longer aspirate post-op. I would say there are no kids that from doing an epiglotopexy have I seen worsening of aspiration, meaning they didn't aspirate before epiglotopexy and after they are aspirating. And if that did occur, which it hasn't in my case, it is a reversible procedure, meaning you can just go in there and divide those sutures and you can sort of have it tacked down if they're really, really not doing well. But I think leaving that rim of mucosa around, I think helps a lot. I can go back to sort of that slide. I think that is really the key, is if you leave that rim of mucosa, I think you're in okay shape. Let's see. Oh, great. It's like auto-saving.
And what are your thoughts on anterior and posterior split for bilateral cord paralysis initially?
So I think it's great. I mean, I've done one case and I think it's great. People used to talk about inserting a micro mini plate initially. They've moved away from that. I think you do the anterior and posterior split, put an endotracheal tube that's larger than age appropriate, leave it in for a week and then take it out. And I think it's a great idea. Once again, it's non-destructive. It shouldn't affect the voice because you're not dividing the vocal cords. So I actually like the surgery a lot. Unfortunately, I haven't had that many cases. I mean, congenital bilateral vocal paralysis is just not a common lesion. So there's that slide I was telling you about. You notice here, as long as you leave this rim of mucosa, I have not seen aspiration. Have you seen aspiration after epiglotopexy?
No, and actually I've seen them getting better. And
Yeah.
I don't know why people don't want to make babies better.
Well, I'll tell you what I have heard of. I've heard of somebody putting a stitch transcervically through the base of tongue, through the epiglottis fully, and coming back around the other way, doing an epiglotopexy that way. And the entire epiglottis just necrosed off because it got strangulated. So you got to be careful about how deep you go.
He's going to aspirate for sure.
Well, yeah.
There's a very interesting question actually here, and it pertains to our culture here. They're saying, how do you convince families of bringing the patient multiple times to the operating room for surveillance endoscopies, and what do you tell them?
So I like to set out the game plan before we go forward. Meaning if a child's got subglottic stenosis and we're doing balloon dilation and radial incisions, the game plan is set well in advance. It's set in advance of even the first surgery. So the discussion has happened very upfront. I think if you start telling them after you've already done the first procedure that, oh, you're going to need a second procedure, a third or fourth, that's where I think you get into trouble. So a lot of what I'm doing is I'll tell them everything right from the beginning. I said, listen, we're going to try to do this endoscopically, but this could take anywhere from 3 to 5 visits to the OR. And after that, if it fails, we're headed towards an open surgery. And so I think having that discussion up front really sort of changes things. Majority of these people don't need a second or third look. I would say a lot of these lesions you can just evaluate in the office with just an office flexible scope. But I think when you're talking about the subglottis or type 3 laryngeal clefts, those are sort of multiple visits to the OR. And I think, like I said, I think setting that roadmap out front, as opposed to popping them, telling them it's going to happen later, is kind of the way to go. Nope, sorry, you're on mute. You're on mute. Oh, you're still on mute.
Unmute. Now I'm unmuted.
I don't know what happened.
The boss has to unmute me. Well, I just want to thank you, Dr. Modi, for sharing your expertise with us. It's been a pleasant 1 hour. I've enjoyed it thoroughly. We really thank you. We're right on time.
The videos,
perfect.
The video stream, okay? Because
the videos the videos and the sound actually was perfect.
Excellent.
We really hope to see you here sometime in the Middle East and get to know you better.
Oh, that'd be fantastic. I'd love to come. Yeah, so videos is one of my passions. It's something I spend a lot of time with. I enjoy doing it. And I think seeing a video of doing a surgery goes so much further than just seeing pictures and diagrams and textbooks. And so I spend a lot of time on these videos, and it's for occasions like this where, a type 3 laryngeal cleft incidence of 1 in 3 million. 1 in 3 million live births, you're not going to see one. But if you do see one, you better record it so that everybody else can see one, right?
Thank you, guys.
That's right.
Thank you, Vikas. Thank you, Talal. Just happened that tomorrow we're going to be conducting like transmission also from Cape Town University. They're also going to talk about pediatric ENT cases.
Okay.
So if you want to join the Cape Town department meeting, it's going to be, you have to go to either the website or the app, and you just push live on it, and we will connect you there. So
that'd be great.
Thank you, Dr. Modi. Thank you, Talal, and have a nice evening.
All right,
My
take care,
pleasure.
guys. Thank you.
Thank you.